Okay, the recording started. We're unmuted. It's your show.
Amber Johnson, I'm going to call to order the Boulder County Public Health Board, or the Boulder County Board of Health regular meeting. It is 5:31 on November 17th. And I'm here with my fellow board members.
Stephen Young.
And Landry Fagan.
Morgan McMillan.
Is that it?
That's it for tonight. Yep.
And we have a quorum. This meeting will be posted on the Board of Health website. The call-in information and address was included and allowed for public participation. Move on to the agenda. First item is public comment.
And we do not have any public comments tonight. I don't see anyone online waiting to make one, so we're good.
Item number 2, approval of the prior month's meeting minutes.
So we need a motion to approve the meeting.
I move to approve the meeting minutes for October.
October 20th.
And I can second, I think, since she motioned. All right, all in favor?
Aye.
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 And motion is approved. Next item is the budget update.
You're gonna do the slides for me?
Yeah.
All right. Good evening, Board of Health members. Thank you for having me today. My name is Armando Guardiola, Director of Administration and Finance here at Boulder Public Health. Tonight, I'm going to walk you through the proposed 2026 budget. You've seen this earlier this year. All we did is a couple updates, but I want to kind of really just kind of go through the proposed budget theme, creating a sustainable future for public health. And obviously our goal was just not numbers, but strategies behind them, how we stabilize our finances, preserve critical public health services, and position public health for a long-term sustainable budget for the next 2 years. And so to add some context, I do want to go back slightly a little bit, kind of prior to why we ended up restructuring kind of the budget and moving towards a priority-based budgeting. So we identified at the end of the year, last year, really, we had a structural budget. So we had some concerns. We're slightly in a negative direction with our personnel, about 81%, operations at 19%. That was for the 25. That was due to really COVID, after COVID, and inflation. So obviously kind of restructuring and moving us more towards a more balanced budget. Also, reliance on grants. As you know, our budget was about 25% based on revenues from grants, very dependent on grants. As the situation with the federal government and even state government, it forced us to really look at our budget and start really aligning our budget with what our needs are. And therefore, that was partially some of the reasons why we started restructuring this budget. We looked at inflation. As y'all know, I'm not going to repeat it, but we looked at inflation over the last 11 years, making sure that we are actually trending with the correct inflation numbers. And then obviously the financial crisis with more of the gaps, the funding gaps. And then ultimately, one of the things that we looked at was a lot of the funding cliffs that we had were prior, or they were due to COVID. So therefore addressing those now that, COVID is over, the funding's kind of gone, really aligning the organization to be a little bit more sustainable. Next. So just quickly and high level, I want to talk about the layers of the structural issues, as we call in the public health funding crisis. We wanted to make sure we address the funding cliffs that I just talked about, the shifts with the federal government, and also the state pass-throughs and the state funding that we're receiving. At the same time, I talked about COVID, so I'm not going to go over too much into that. And then ultimately, we wanted to make sure that we preserved our assets, which were really our personnel. So we took that into consideration for this funding crisis. Go to the next one, please. and I'm sure you've seen this many times this year, but I kind of want to talk about just real historically. Steve, also for your knowledge, we went from incremental budgeting probably the last 11 years. We went to base budgeting last year, a very small change, but really helped us with the 5%, really addressing more on operational. We didn't really we really didn't look at the personnel. It's just too short. I just started in September, but we made a quick 5% adjustment to get us for 25, looked at the inflated budget. Really for 26 was really the task that we were addressing is the structural, the budget that was some structural impacts that we needed to address. We worked with obviously the teams, and we implemented priority-based budgeting, and therefore we've been working on that all year, really addressing how can we be a more sustainable organization through difficult times and through financial crises. So I believe what we have today will get us there for the next 2 years. Go to the next one. So along as we move forward with priority-based budgeting, there was a couple of things that I wanted to kind of address. One of the biggest things was we wanted to prioritize, or our programs wanted it to be sustainable. So we looked at, for example, any programs that were self-sustainable as far as the fees. We did fee analysis. We wanted to make sure that we understood our programs. Second of all is we looked at non-mandate programs and right-sized them. Those were more of the grant-funded programs. So we really looked at those programs, and that's how we determined what sizing that program should have based on the funding. And then ultimately the subsidized high priorities. So going through priority-based budgeting, we identified a handful of programs that scored very high based on a scorecard, but had no funding attached to it. So we prioritize flexible funding to be able to subsidize some of those programs, and hopefully we can start addressing some funding or additional types of revenues so we can keep those longer, but really trying to address programs that were really impactful to the community based on a scorecard. Next one. And so I'm going to give you a quick preliminary, and then we'll go into the source and use, but overall outcome that we have right now is we reduced the budget by 3.8 million compared to 2025. There's been a lot of hard work by division managers, supervisors, this whole organization, leadership. Not something very easy to do, but ultimately what I present to you today is a $3.8 million reduction in the budget. If you see at the second bullet point, I want to talk about the reduction in FTEs. As y'all saw prior, we broke down the FTEs, even though we reduced the FTEs by 40.6 compared to 2025. Some of those were layoffs. Some of those were term positions that had no funding that were attached to grants. Some of those were repurposed positions. Some of those were attrition, which were vacancies. So that 40, I just want to make it clear, the 40 does represent different types of reductions in personnel, but ultimately we reduced it by 40.6. We did preserve prioritize programs and services by reinvesting some flexible funding into maternal health, immunizations, and prevention. That doesn't mean that they did not have to do reductions, but we did keep those programs that had no funding associated to them, at least intact, to be able to be sustainable for the next 2 years. And then ultimately, we identified 33 process improvements that we're currently working on. On top of that, I think we've identified even more. We're working with the divisions to prioritize which process improvements have the best ROI for the organization so we continue to be sustainable. So I always like to show this source and use. It's real important. The source and use, if you look at the right-hand side is the one I'm going to talk about. So if you take a look at our source and use for 2026, our sources are it's a $20,610,639 budget. If you look at 25 compared to that, it was a 24.4 million. That's where you see that 3.8 million. What I do want to point out here in the sources is if you look in 25, we earmarked $2.1 million of reserves, which is our fund balance, to be able to balance our budget in 2025. In 2026, we're only using 691,000, which is almost a 60, don't quote me, I don't remember, but I think it's 66% reduction, which means we'll preserve our fund balance for the next 2 to 3 years and be able to make it sustainable. One thing about fund balance or reserves is once it's gone, it's gone. And so we're really trying to be very cautious in how we use the fund balance. So we've done an amazing job tackling the deficits within the fund, within the revenues to be able to address that. And so right now, for 2026, we'll be earmarking 691,533 in from the fund balance. If you look at our expenses, I'm not going to go into too detail, but every division had some type of reduction. We looked at all the reductions that were recommended, and we did fee analysis, or we did a feasibility metric and looked at every single recommendation that came forward for us to determine which ones we move forward as a recommendation and ultimately to implement, and work with the division managers. So as you can see, we went from expenditures of 24 million to a presented budget of 20.6 million. So that's that $3.8 million reduction. So a lot of work. Slightly different than what I presented to you in August. We presented a 20.6, or it was a 26,640,000. I bring to you tonight 20.610, so about a 30,000 reduction if you go back to the slides. So slightly better. But I believe that's a really good number to be sustainable over the next 2 years. Ultimately, looking at 3 years, I'm careful. I want to be very conservative, so I'd be comfortable saying that we're sustainable for the next 2 years. We'll continue to monitor for year 3. Questions? It's a lot of information. Any questions?
I do.
Please.
So, excuse me, just when you project out your budget, so 2026 is there, you talked about long-term budget sustainability. Do you differentiate between like short-term, medium-term, and long-term? And what does long-term mean in this situation? How many years that are we talking about?
So I'm going to answer it as best as possible. So in a normal fiscal year, I would say a 3 to 5 year would be the long term. Just because of the environment that we're in, the financial environment, I have to be very conservative. And so what I'm going to show you the next couple slides, I'm going to talk about fund balance, and I'll show you what I believe I am sustainable for the next 2 years. I would even include that more of the long term. I think in the environment that we're in, I'd be cautious to say anything past 3 years. I'm kind of throwing things on the wall to see what sticks, just because the uncertainty that we're in.
Do you ever model out like midterm, like year and a half out, and see what that's like?
Yeah, so what I'm presenting today is a 2 year. So I have a 2 year.
Okay.
I actually have a 3 year, but I don't present it today because I'm being real conservative. But if you take a look at the information that I sent you, I did put a graph in there on fund balance, and you'll see where our reserves. One of the things that when we're also trending or projecting, I got to take in consideration what we have in fund balance, which is our reserve. And so that number dips as soon as I start using that fund balance. If you take a look at it, that 2.1 million in there. Right now, this year, we went into about a 19% reserve. But after this year, if I use that 2.1, I'll show you on the next slide, we're down to 17. And then the following year, if I project, we have to even lower that amount because we still are using some of the reserve. So that drops down to a 15%. And our policy is 15 to 20. So I'm real careful with that. And so I'm trying to preserve as much fund balance within this year and next year to be able to move us another third year would be sustainable.
And how does that get replenished, this reserve?
That's the problem. It doesn't get replenished because we don't really have any direct revenue coming in. We have a transfer from the county. And so that's why I've been really pushing the executive team to one time, right? Because we can't use it for payroll. Payroll is an ongoing expense. And so I've been real careful about saying we can use reserves, but it should be a one time. We were actually funding payroll, and that's an ongoing. So it's changing the philosophy to be able to do one time.
Armando, can I add?
This,
Morgan, just real quick, I wanted to share with Stephen, I think the concern that we have at the federal levels is on that top line with the grants and fees. So given that 25% of our budget is grant our grants, and then we collect indirect funds that help to pay for our administrative costs. That is very concerning, because we are projecting that we will not continue to receive the same level of federal and state funding that we have in the past. And so I think, to Armando's point, we've been very careful about trying to project out to the past 2 years, knowing that we have enough reserves saved from COVID, that we had COVID funds, so many in COVID funds, that we're not going to get replaced anytime soon. Sorry, Morgan, go ahead.
Oh, no, I just think that, Stephen, what you're getting at is something we've talked about for actually the last couple of years, as we've been looking at how much we've been using reserves, and also the concern, and why we set a minimum reserve policy as a board a couple of years ago, is because this money is so hard to come by. Like, we don't have a way of rebuilding our reserves, really, because so much of our money comes in with, a stipulation that you spend it all out. I think for years, the county did not have that, and that's where we were able to build it up over the years. But now, I think that has changed, that expectation has changed. And so it's why I think we decided to set a policy around keeping a certain level in there.
All right, thank you. Do we have time for a few?
Yeah, sure, please.
Sure. I just took a couple of notes. So when you talked about right sizing, what mix of personnel versus other costs are you considering? Because you just talked about just general right sizing, and I'm not clear on.
So when you look at right sizing, if you look at the GOFA, the recommendation depends on the size of the organization. You're looking at a 70-30, right? 70% should be personnel, 30% should be operating. And the reason why you want more of a higher number on the operations, so when we have some type of financial crisis, we can directly go to operations instead of cutting personnel. We're very high even this year. I think I have to go back and look after we adopt to see where it's at, and I'll present it, or I'll send an email maybe on the next report. But we want to be, I would say, if I was to be, if I was to have the full control, it'd be about a 70-30. That's a good number, because that way I can address a crisis by attacking operations and not personnel. Does that help you?
And I also think, Armando, in 2024, our first attack was operations.
Mhm.
Okay, we're going to cut our operating. And then we realized that is not sustainable. And so we realized that we were going to have to make the difficult decision to cut the personnel.
So just as follow on, so you're 40.6 FTE reduction. So that's part of that right sizing process.
Correct.
And then, so that's not going to come back. That's basically has been eliminated.
That's been eliminated.
Okay. And is that equals about 3.8 million? Is that?
Yes, that actually, well, there's some small operating that got cut also, but you take that in the 40, that's where the 3.8 million is the reduction.
Okay. Just final question, sorry.
No, good.
This is all new to me, so I have a lot to learn. So I'm looking at the expenditures next year. Big drop in community health and SI. I'm sure you guys have had lots of negotiations on. Is that mostly FTE reduction as well?
The majority of our budget reduction is FTE. The reason why you see a little bit more there is those are the programs that we talked about that were priority programs, scored high on the scorecard, but had no direct revenue streams to fund them. And so they're either grants that expired, and so we don't have any funding, or they don't have any fees. So for example, if you look at environmental health, they have fees, so they can actually be self-sustainable. If you look at our vital records, we cut down, originally there was 8 employees, we cut it down to 4. Now that program is 90% self-sustainable. Originally we were subsidizing almost 900,000 just to keep 8 employees to do vital records. So those are some of the things here. Those are some of the changes that we did to implement priority-based budgeting. Just gave you some examples.
And the reduction in FTEs, what kind of impact has it had? Have you received any feedback?
So we've had to provide kind of the impacts to our commissioners, to the board, even to our constituents, even our partners. The problem with that is really we're still, this year's kind of a baseline, because we really don't know the full impact, just because I think we were kind of inflated. And so I think this year, as we continue to measure and monitor, I think we'll really have a better idea of the impacts. But there's definitely going to be impacts. Anytime you have some type of reduction, there's always impact, right? Because we have to look at are we doing the right things? So what is added value versus non-added value? But I would definitely have to say that this is the year for really to look at, what kind of impacts and start assessing that, because then we're gonna have to make some changes.
And we did do some internal hiring. We did it. So we set our own policy to do internal hiring, meaning that the jobs are not posted externally at all. They're not posted to other departments, they're just posted to public health staff. And that has allowed us to do kind of workforce alignment. So if someone's job was ending and they knew it was ending, they could apply for another open vacant position. And so this allowed us to kind of have people shift into other roles because we tried to do as much as we could to preserve our staff. They're our greatest investment and they're already enculturated into our culture. And so what is a small amount of training, to invest in a staff person learning a whole skill? And we have been very successful with that.
And you said that's a new policy?
We implemented it. We knew that we were going to have to make cuts, but we also knew that new positions would be coming up due to retirements, vacancies, and all those things. So we implemented it in May of this year, and we got the county's approval from the human resources because it's not something that they should typically do. But knowing what we were going through, the county was very supportive of moving in that direction.
So there are no legal issues or anything like that?
No.
No, I definitely work with legal and I usually go with HR, even with all our sunsetting of positions. I've been working with legal and HR. We've done 3 memos. We've even built some policies as far as how to fund some of these programs because we didn't have any funding guidance. So at least now we have that type of funding. Division managers kind of know what to expect with grant funding, how it works, how we spend it down. We didn't have some of those controls, and so we've had a lot of those controls this year.
All right, thank you.
More questions? Those are good questions. So next slide, please. So I'm gonna move on. Something that I present to the board as I started last year was really on the reserves. I think Morgan touched a little bit on it, is making sure that we're within policy. So if you take a look at the 26 budget, at the beginning of 2026, we will have a 17% budget, which means if we use the $2.1 million that we earmarked for 2025, we will start our fund balance at 5.1 million. As you can see, we're only balancing our budget with 691,000. So at the end of 26, we will have a $4.4 million budget. And on the next slide, I'll talk about what that looks like for 2027. But right now, based on that information, or based on the adopted budget that we'll bring back to you in December, we'll have a reserve of about 17%. Next slide. And so, Steve, this is a little bit of the projection I think really paints what we're set for 2026 and 2027. I feel pretty comfortable based on these numbers. If we can preserve and stay on budget, if you take a look at the 2026 will be at 17.9, but if you look at the 27, the last column on 2027, if we stay on budget for 2026, we'll have a 15% budget and be able to still be sustainable for 2027. The other thing that you don't see here is on the 28, it slightly drops, but I still believe that we can preserve some of our fund balance this year and next year, that we'll be able to project over the next 3 years a sustainable budget. The other thing, we still have some process improvements, and we're also looking at fees. We did a lot of analysis, so now we look at fees at least every year, so we kind of know where we are sustainably and what are we subsidizing for these fees and these programs to make sure we're right size. So right now, what I project tonight is only 26 and 27. I'm pretty comfortable on 28 if we can preserve our reserves some this year. Questions?
No, that 15%, does it represent 3 months of carrying the agency if we had no funding? Is that?
No, it's actually going to be more. You'd have to be lower to get 3 months. This is based on just the policy that was adopted by the board.
Okay.
So we have slightly. Okay. Next steps. One thing that I want to be clear is we have not received the finalized county revenue transfer. That is going to be December 9th is what I'm hearing from the county. We did get an approval as far as moving forward with the S tax, which is a revenue That was approved, but we are still waiting on the transfer from the county. We hope to get the 7 million. We'll continue monitoring that. I know that they are working on some reductions and they're still working on a deficit that the county has itself, but we are hoping that we receive our 7 million, more to come. If that happens, then obviously we'll come to the board and show you the impact that it has on our budget. The next thing also that we're working on is
Hey, Armando. Sorry.
yes.
Sorry to interrupt you. Before you move off of that, I thought that there was some sort of also approach that they were considering where the 7 million would be adjusted for increases in salaries, for instance. Like
there.
No, we are that's not that's what we're working on the IGA, but we can talk about that on our subcommittee. But no, it's a flat 7 million, and that's what we have in the budget.
Okay. Yeah, I mean, I think because we try to follow what the county does also in terms of cost of living increases and merit increases. I think at one point we had talked about asking the county to consider increasing the 7 million to be reflective of those increases as well, especially since the majority of what they're paying for is for positions. So I just want to be sure that we don't lose track of that ask.
Absolutely.
It sounds like it sounds like it might be a done deal this year, but I do want to like revisit that because I do think that's an important thing. If we're continuing to get a flat amount from the county year over year, but our expenses for personnel are going up every year, right? Then that we lose.
Absolutely. I think we're addressing that with the IGA. Morgan, I can get more information to you.
Okay, thank you.
The next thing is we are reconciling our budget with OpenGov. So in the past, in 2025, we were able to reconcile our budget with OpenGov. It's the system that they use for budgeting. So unfortunately, we don't have a budget system, so we do a lot of Excel, and then we have to go in and reconcile. So that's what the team is working on right now. So by the time we adopt by January 1st, we should have a reconcile budget with OpenGov. So that way, if you go into the system, into OpenGov, you can see that we align and it looks exactly what we adopted. The next thing is we are also working on completing the GOFA ready budget book. Last year we submitted for the award. They gave us kind of a metric. So there's a couple things we need to add and we'll be applying to get that award. Hopefully we'll get this year and it becomes just a standard and making sure that we get the award for the GOFA. And then the next thing is we'll bring this back in December for y'all to adopt. The only reason why we have to wait, obviously, is that we're waiting on the county to finalize that 7 million that we're requesting. And hopefully that comes through with no adjustments and y'all see the same budget that I present tonight. The other thing I want to kind of talk about is the team itself. The finance team has been awarded the GOFA Award of the Year for Colorado based on our priority-based budgeting work. So we'll be accepting that award Thursday at their banquet in Loveland. So it's a big thing. We got this award for doing priority-based budgeting. It's a statewide out of all the municipalities, government agencies. We got this award for priority-based budgeting and the work that we've done. So. Yeah.
Well-deserved recognition. Congratulations.
That's it. Any questions?
So the measure that was recently passed about mental health tax, how is it going to impact what we're seeing?
So we're hoping it has a positive impact. Right now, we are waiting. We did provide a proposal for them based on the services that we provide, and then the commissioners are, I think, are taking recommendations or proposals from others that have some type of impact, and then ultimately they hopefully will get some revenue assigned to us, and then we can go back and amend the budget. Cross our fingers. I'm hoping that we get a good amount. We have programs that provide a lot of services to the community and would definitely help our budget. With that, we're hoping not to expand, but provide more services and keep our budget in line. I think we're at a good budget right now based on just the numbers. The numbers say we should be around what we're actually bringing forward as an adopted budget, but I think we can still provide a lot of services to our community. So we're waiting. I think we will have something hopefully by the end of the year. If that does happen, we'll amend the budget, and that won't happen till about first quarter.
Any estimate on what that amount would be?
I don't want to jinx us, but I do have an idea. So I think anywhere from $1 million to 3 million, but I don't know what that looks like. It might not be any, but it really is up to the commissioners. I think the proposal that Lexi and Endura put together, I think is really solid. I think Tessa helped also writing it. So I think I feel comfortable. I just really think it's going to be the commissioners making that decision.
I guess I'm a little bit puzzled. So mental health, why would not everything come to public health? I mean,
I just love you, Steve. Yes, I think Lexi's gonna join us here in a minute and she's gonna talk a little bit about what our space is. So I think the biggest challenge from my perspective is that the community is, the community is really involved in trying to get more treatment options. And so sometimes the prevention, early intervention, and harm reduction aren't as valued because there's such a big demand for treatment options. And so I think what we have been doing is trying to kind of make the case that we have to be upstream. People, what is the old saying by Desmond Tutu? You're pulling bodies out, right? Like, what's happening to them upstream? How come those people are falling into the river? And so we are really working hard to kind of make the case because we have some great, unique and prevention programs at this agency that we would like to see stabilized and funded, including work with, new parents. And we have the data to show all that the places that we need to put our resources. So Lexi's going to talk a little bit about that, but I think from a community perspective, the first place people do go is treatment. And so we're having to make our case as to why we should be focusing upstream. Yeah, it's unfortunate.
Yeah.
Okay. I think Morgan.
Yeah, I mean, I volunteered on the initiative, and I think that there is going to be a lot of balancing act for the commissioners also because there's a lot of expectation from community organizations that this money is spread in the community to NGOs who are not part of the county government. So I think that's also going to be something the commissioners are going to have to consider heavily. It's also only a 3-year tax. So whatever it is that, if public health is able to be a part of it, and I hope that we are, it's going to be, really important for all of us that receive any funding to be able to show impacts, which is hard to do in a 3-year time frame if we want to go back out to the community and ask for a renewal or an increase or whatever it is. It's a pretty short timeline. So I think we want to be mindful too about what are we putting forward and are we going to be able to demonstrate impact in that short timeline?
Any other questions before I finish? All right. Just really quick. We know it's been a very challenging period structurally, financially, and emotionally for everybody in this agency and the community. My team and I are committed for being, my team and I are committed to being transparent, responsive, and data-driven as we move forward through this transition. We appreciate your leadership and partnership as we work to create a sustainable future for public health. Thank you.
Context was had recovery and
Armando, I didn't know you won.
Huh?
I didn't know you won.
Yeah.
That's amazing.
The whole state.
Yeah.
Right. So good evening. Well, I hope that, I can bring up the mood for the room here by talking about bioterrorism. After talking about the budget, it seems like that could be possible, but no, actually, we're going to share some very positive things about recent exercise series we had that we led. And this was last month. I'll get there. But yeah, just appreciate the opportunity. So again, good evening, everyone. My name is Chris Campbell. I'm the emergency manager with the agency with Boulder County Public Health. And get this off. Carrie and I were co-presenting. So Carrie Middleton is joining me. Carrie's the emergency management planner with Boulder County Public Health as well. So we really appreciate the opportunity to share a lot about this exercise series. We worked really hard over the last year on. So, turn it over to Carrie. Yeah, I'll do. I'm changing the order. Go ahead, Carrie.
We're improvising on the fly. So good evening, everyone. Thanks for having us here. As Chris mentioned, I'm Carrie, and I'm just going to provide a little bit of context about this exercise. Patrick or Dahlia, thank you so much. Whoever's the master of the computer over there, thank you. So I first want to point out the stuffed kitty. So we're changing the mood from budget to happy things. So in all seriousness, the unofficial mascot for the emergency management team, it's a long story, is Emergency Cat. This was a multi-day exercise. The first day of that exercise, I neglected to bring Emergency Cat and I was called out on it. So one of our best practices apparently is making sure there is a stuffed cat for exercises. So for this exercise, we really just want to talk about the value we get from exercise and training in general, but this one specifically. Talk about some of our key takeaways, Emergency Cat aside. To provide a little bit of context, this was a regional exercise. It took place over several days in October. As a regional exercise, there were lots of partners, both local to Boulder County and outside Boulder County, that participated. So hospitals, local public health agencies, the state health department, local emergency management agencies, and hazmat authorities. The scenario for this was an aerosolized anthrax release at Ball Arena during a concert.
With anthrax.
Yes.
Anthrax concert.
Anthrax, that's what we called it locally. The regional folks had something much more sophisticated sounding, but because we're Boulder County, we went with anthrax. So a couple of things about the scenario. One is that we don't necessarily think this is a big hazard in Boulder County per se, but for reasons that we'll go into, given that this was a regional exercise, it also made sense for us to take advantage of that regional exercise opportunity. And we'll talk a little bit more about that. The other thing about the regional, about that scenario is that we train in case of an anthrax exposure to very quickly be able to provide antibiotics to people who are exposed as a prophylaxis. So I'll just kind of leave it at that, just to provide some context for what this exercise was about. And I know several people in this room participated in it, so we can all present, really. Okay, up next slide, please. So I mentioned this is a multi-day exercise with lots of partners. We had 3 different components to this exercise. So one was just that initial coordination with partners as the incident began to unfold. Another is what we call a departmental operations center activation. This is where our internal incident management team comes together and starts doing response work or planning response work. So we had that where our incident management team folks came together, and bringing us to the third component of our exercise play, which was holding a point of dispensing drill. So during that Department Operations Center activation, we were planning what would this point of dispensing look like, meaning we're dispensing antibiotics to impacted community members. Actually, staff and volunteers were playing that role. So if this sounds like a lot of work, it's because it is. And we had over 50 both Medical Reserve Corps volunteers of Boulder County, as well as staff participated in this. And the reason that we do this, the reason that makes all of that preparation worth it, is because it helps ensure us that we are prepared to support the community in case of an actual incident or emergency. So we train before we exercise. So of course, we're training our staff what to do in the case of an actual incident. And then during the exercise, then we practice actually doing it. This is especially relevant now when, as with staff turnover, we have new staff who are participating in this team. They don't have a lot, or in some cases, no experience in emergency or disaster response. We also, just like we don't respond to an emergency or disaster alone, we don't exercise alone. So these exercises give us a chance to work with key partners to make sure that before the emergency happens, we know who should we be talking to, what are the organizations that are relevant, And we're all on the same page about what our respective roles are in that incident. It also gives us an opportunity to test plans. I don't want to steal Chris's thunder, as we talked about before this meeting. But one thing I would want to say is that, so this exercise series helped with all of those things, that training, that exercise, and reinforcing partnerships. But the specific scenario also helped address some of the gaps or areas of concern that we have identified in the past couple of years. And one of those is needing to be sure that we're prepared for a chemical or biological or radiological or nuclear or explosive incident, which this was one of those things. Another reason that this particular exercise was important is because during the pandemic, there were concerns about how do we as a local public health agency coordinate with the state health department to acquire materials such as antibiotics from the Strategic National Stockpile. So this allowed us to test some of those specific things and explore some of those specific areas that we know that we need to continue developing. So I will turn it over to Chris.
Okay. Next slide. Thank you. Okay, so Armando actually set this up really well. So and Carrie did as well. So we really like to do these exercises to build capacity with our partners, to build capacity. We actually had a component working. It's fascinating how everyone kind of wanted to test things. It had been a while since they've been in the field. So the hazmat authorities were actually out all through the metro area testing, actually running tests to see if they could look at bioagents. Our environmental emergency response team joined that and observed and kept that relationship going. So that was a really positive finding we had here. But what we do know is our federal partners are resource constrained. Our state partners, the state health department, are likewise going through some of the things we're talking about, loss of institutional knowledge. So we really wanted to continue to build our capacity, use this exercise to ensure staff are comfortable in their role in a department operations center. If they're operational and they're handing antibiotics out to the community, are they comfortable with those roles? So they understand what they need to do. And they can use their subject matter expertise to really work on that. So it really didn't matter about what the topic was, again, with bioterrorism. I think it should definitely be recognized, the incredible work that Carrie did, along with Colleen Sinclair, who's also on our team, preparing this exercise. Amber, you were here, and I appreciate you being here for our department operations activation. There was staff there in our operation to do appointed dispensing. It takes an immense amount of work to think about the scenario and make it meaningful for all the partners. So we did a lot of training this year with community partners, with our staff, to make sure that we're prepared for this. So, it's, and then we really heard from our staff that they were tired of having scenario-based conversations and kind of hypothetically talking about things. So we said, okay, you can start doing things. So they were out, they were next door here. I keep pointing over here. Folks can't see, but we were doing our point of dispensing using bottles from the some strategic national stockpile to hand out antibiotics, and we really learned a lot from that. So, but we also recognize that this is the time to build a capacity. We are going to have to leverage all of our staff. They need to understand what we're working towards together, along with our partners. Next slide. You might have heard me say this a lot about partners, but we certainly can't do this alone. We're all small teams. We work incredibly hard to work with our partners. The hospital partners we work with are incredible in this community. I mentioned the Hazmat Authority. We work with Medical Reserve Corps as well, which has been incredible. So using that expertise in the community of medical practitioners that volunteer their time to support us. And those who have been with this board for a while know that the incredible work that group did during the pandemic. They were right there with us when we were doing our point of dispensing. So we continue to build that capacity. We still get volunteers today asking to join the Medical Reserve Corps. So we also work really hard on our work in the region. These things certainly don't know borders. We know that. We know outbreaks don't know borders. We know that incidents like this can grow large very quickly. I'm the chair of the North Central Region Public Health Committee. We actually have a coordination plan. And so I held a call with that group to talk through what are we seeing? What is happening in Denver? How is this impacting Arapahoe County? How is this impacting Adams or Douglas County? So we were able to test that and it was really successful. And our state health partners, they've been through a lot and we're really pushing them to kind of reset. Let's look at these other scenarios like accessing the strategic national stockpile. There's lots of work to do there. We have a federal system that has been down for a while to track inventory management. So we really want to get back to make sure we have that system available. And if we do need supplies from the strategic national stockpile, we do that in a very organized manner. So worked on that. And I really want to call out Boulder County Security. So they're a key partner, and I think we went through a lot with them during the pandemic response. We asked a lot of them. We used a lot of facilities to do mass vaccination. Their whole team came to the exercise, our pod, and were incredibly helpful and really wanted to learn. And I think that was one of the biggest positives we had out of this exercise was working with security. So if they're watching tonight, would watch the recording. I really want to thank them for their participation. So I'll keep going here. I could talk all night about this. Next slide, please. We might have seen some in the past, but we really like to do detail what are called after action reviews or reports, and we do an improvement plan with that. So we really document. We do surveys. We do a hot wash right after these. All the days that we had this exercise. These are some real general things, but we get really weedy on this. Very operational details around, actually working with Dr. Belknap on standing orders or what does it look like? Can we crush if someone is unable to take pills? Can we crush the antibiotics and can they access those? So these are operational things we work through and documented where we needed to improve, and we will have kind of timelines out there to get those implemented. But again, we're going to continue to work on that ongoing coordination with the state health department as key partnership. These operational details I mentioned, and just again continue to work with our policy group and Dr. Belknap on making sure things are in order if we have to do a point of dispensing for this in the future. And again, I really want to thank, everyone I want to thank our teams, our incident management team. These are other duties assigned for this group. So we do pull them in. They're incredible subject matter experts. So they're here to really problem solve with us. And they did that during this exercise. I really want to thank Carrie and Colleen again for their support and the agency support on this. And we'll knock on wood. I hope we don't see something like this, but I think the community can, we're looking forward to this, and we're going to continue to build that capacity.
Thank you, Chris and
Yeah.
Carrie. I mean, I think this exercise was so well done. And I felt like all the staff were very well trained. And, you're right, with the capacity issues that we're going to have in the future, I think you have really educated everyone about their role and, these things could happen, right? So we had our train derailment, right? That was the one that kept me up at night, and then that happened. So you never know. So super grateful for.
Thank you there. Yes.
And I just wanted to mention the fact that the Netherland fire happened right during the thing, and it was pretty seamless. That the fact that the real world scenario happened, and they just kind of, without missing a beat, the people went that needed, and the people continued. So it was pretty amazing.
That's one thing we always talk about, an incident within an incident. So that did happen. So we had another response. I had to kind of step out, and we had other staff step up and actually on that day run our point of dispensing. So it was amazing. Rachel Mintle, definitely want to mention. So Rachel stepped in and actually jumped in as the pod manager and we're in the operation. So just incredible staff. I really appreciate them. Steve, yeah.
Chris, thanks.
Yeah.
I'm not familiar with this whole incident management world. Do you have a template that you use to start the exercise? And I guess I'm wondering, in terms of beyond Colorado, other states and other local public health agencies, do they use common blueprint with, I suppose, local variations, or how like this kind of exercise, how does that go?
So yeah, I want to make sure I'm understanding your question. So absolutely for the exercise, there's templates there. We have an exercise plan that we go through and we look at objectives. I would say that we have an emergency operations plan that has our structure for our incident management team. So that is organized basically under what's called the incident command system that you might be familiar with. So this is that's how we organize. So we actually have plans for all these different scenarios. We have annexes for those to kind of direct what direction we go for our staff. So is that answering your
Actually,
question?
I was asking more about, beyond the exercise, whatever the response happens.
Yeah.
Hopefully it's something that you have practiced and exercised so you can actually respond to it.
Yeah.
But does that follow some kind of national guidelines and how often does that get updated now with the FEMA on its deathbed? Do things change, or I'm trying to get a sense of, because I just read about the FEMA director resigning today, so it'd be very difficult to rely on federal response or help for them to come back. So
There are standard federal guidelines. Chris referenced the incident command system as one. It's really, which is part of the National Incident Management System, which jurisdictions across the country are all supposed to be using. So it uses common terminology, common ways of organizing. So to your point, we can talk to each other across jurisdictions, including across states. With FEMA, with the way that it is, I don't see that doctrine going away, but I would also say that there's always a little bit of variation in terms of how doctrine gets implemented from place to place. But theoretically, we're all using the same basic frameworks, if that helps.
And it's really important because, we're one department, so we have our own department operations center. But if you have a larger disaster, the county will activate their Office of Disaster Management, and we fit right into part of their disaster management. And so I have found in my time, I was the division manager for 10 years in the division, the incident command system is the way to go because everybody stays in their swim lane. And it doesn't matter if you're working with fire or EMS, or you're working with law enforcement, or you're working with a hazmat team, or you're working with human services. Everybody knows their role and responsibility and stays in their swim lane. And so I think that is what has made our success as an agency, and I think it has provided the structure for the county for a very long time.
And that's really one of the value of having these kinds of exercises is because if you are not used to working in that structure, it can seem artificial and strange. So it's getting people comfortable and familiar with working outside the normal business structure and inside the incident command system.
Even if FEMA goes away, I still think that ICS system will stay. I think so. Yeah.
Yeah.
Sure. Okay.
Should have brought emergency cap.
We talk about very heavy topics and we like to have fun, and we do have some mascots. So thank you so much for your time. Yeah, take care.
Thanks, Chris and Carrie. It was great to see. I mean, my only professional touch points with this is just medical drills, right? And
Sure.
to see you all doing it with relatively high fidelity, right? Not just talking about it, but physically doing it was fascinating.
Thank you for that. Yeah, it's helpful. Thank you.
Item number 5, Lexi joined us. We're going to talk about mental and behavioral health planning. Hey, Lexi.
Good evening, Board of Health and
Oh, did I jump
colleagues.
ahead?
Lexi
house.
Nolan, can you hear me?
Yes.
Okay. Lexi Nolan, Director at BCPH, and we're going to talk a little bit about some of the work that we've been doing in mental and behavioral health planning in relation to really recognizing that we were going to have to restructure some of the work with some of the changes in the agency. But before we get started, Sean Hollister is going to share with you all the output of a particular campaign that we have been participating with. And Sean, I'm happy to turn it over to you for a little while.
So thank you very much, Lexi. Good evening, everyone. My name is Sean Hollister. I use he, him, his pronouns. For everybody who hasn't met me, I'm the communications manager here at BCPH. And I was lucky enough to be part of the mental and behavioral health strategic priority working group. And that's really where this project started. For those of you who've been here a little while, you might remember Dr. David LaRocca. He really got this project going. And so I just want to acknowledge him before we get started. Some of you may be familiar with the Let's Talk Colorado campaign. It's a statewide campaign around health-seeking behavior around mental health. That was launched in 2015, and it's been so well received that they relaunched it and dedicated some new resource to it this year to launch it again with a new look and feel, some updated resources, some better tools, some new interviews, that kind of thing. We were really inspired by Broomfield Public Health, who in 2015 created their own version of the campaign focused on people in their community, specific people from their community, which was really effective. So David and I met with Broomfield 2 years ago to just talk about their experience before we started down the road of creating a Boulder County specific campaign. So one of the reasons Let's Talk has been so successful is that it focuses on real stories from community members. People are much able to see themselves in those local stories and to promote strength through storytelling. So genuine stories. So that's the statewide campaign on there on the right. And thanks to them, we were able to use that campaign as a launch for ours. Our goal was really around the same as theirs, reducing some of the stigma around mental health, promoting some positive narratives about mental health experiences rather than what overall tends to be negative. And we wanted really people to feel comfortable with asking for help, because that's where a lot of people get stuck, is in that first step, especially within specific communities in our county. And we also wanted to foster some community connection and support, and we've certainly done that through this process, through the project. So what's in the campaign really focuses around our heroes, which are our video storytelling series, which features those local people. But we also supplemented that with some flyers and social media graphics, some press releases and targeted media outreach. So we're picking up the phone and calling the journalists who we know in the area and talking to them about the project. And then we wanted to create some language access, so it's in both English and Spanish. So here's our heroes. As I mentioned before, these are some social media graphics that we used to promote the video. So we had Lalo, Char, Sarah, and Monica come forward to share their stories, and they're really the heroes of our campaign. So I want to take a minute and just quickly share these videos with you, and hopefully there won't be any problems with the audio. So Lexi or anybody at home, if you're having a hard time with the audio, please let us know. That was our montage video. I want to take one moment and share the next video with you because I found it especially moving. I do want to warn anybody who's watching, it does address suicide. So if you have any issues with that, you might want to consider that before watching. Excellent. So I just want to highlight that this was really a very collaborative effort. I want to thank the people in the community who volunteered to come forward and share those really vulnerable stories, because that's hard to do. There was a lot of people that we had to turn away. The response was really amazing. So to the community members who put themselves forward but weren't selected, thank you for that. Our strategic priority working group is fantastic, but really our programs came to the table. Without their help, we wouldn't have been able to do it. So all our teams in community health across the agency who really put their work down for a little while to help get this project going. I really appreciate that. We also had a lot of partners from across the county MDPH, the Metro Denver Partnership for Health, was instrumental. Broomfield, again, like I said, they really helped to get us in the right direction because they had done it already. But the Let's Talk folk were fantastic. They let us use all of their artwork and things, and that saved us a lot of time and resource. We were able to pick it up and run with it. But also mental health partners with Clinica. And just a shout out to our partners at Barefoot Public Relations, who've been a real partner in this, and they really went the extra mile to make it a fantastic campaign. So I'll just go, what can people do to help? Watch the videos, share them on your Facebook page, send them to your friends. Our analytics, the more hits we get, the more that feeds into the algorithm, and more produces that for other people. So just keep watching them, keep sharing them with your friends and family and coworkers, and that'll really help us get the word out.
I got a question online from Morgan.
Yes, yep.
Thanks, Sean. These are really powerful, and I appreciate the work that went into them and the community volunteers who stepped up to be in them. Is there like a structured strategy for pushing these out into the community other than like, hey, share these on your Facebook? But I mean, do we have partners that have strong networks that are pushing these out? And also, what are the platforms that we're using? Because it's, I just would love to see. Yeah.
Yeah. So we've been working with our partners at Barefoot. So we did a really strategic media out push with them that included press releases and contacting media relations. We're also doing an ad buy for social media. So we've got some banner ads across several different platforms, driving people to our website. We also have the videos on YouTube, and we're promoting those. In addition to partners, as I mentioned here, at the county and their mental and behavioral health roadmap, that team is helping us share it. Our partners at Mental Health Partners and Clinica are helping. So it's like I said, all of those agencies have really come to the table to share those stories out with their networks, to keep the conversation going and to help us get the word out. And in the future, hopefully, if we have the resource and time, we'll be able to go back out to those partners and continue the storytelling. That's the hope.
Great. Yeah. I mean, it sounds like there's probably, I mean, Clinica and MHP are obviously NGOs, but thinking about other NGO partners in the community that have a focus of mental health and how can they help also get the messages out to their contacts through social media and other spots.
We leveraged off of we have a community and cultural communications and cultural brokers quarterly meeting or monthly meeting, and they were really helpful in getting the word out as well.
Great, thanks.
Do you do any outreach directly to school districts?
We certainly work with BVSD and St. Vrain pretty closely. I mean, the PIOs, the comms people talk about campaigns quite often. There's no formal process with this campaign with them, but we have a pretty strong relationship with both districts.
So that's actually what I was going to bring up, is that it may be that the school districts, for instance, they do education in the mental and behavioral health space. We could certainly make these videos available for them to use in that process.
And probably CEO as well, Ben.
And when I launched the campaign, an email went out to all those organizations. So we have an established PIO network that meets quite often, and that includes NIST, CU, sort of PIOs from across Boulder County, and that was shared out through them. So I'll hand it over to Lexi now, maybe to address what's next for the MBH space. I know we touched on it a little bit earlier, Lexi. I think maybe before you got here, there was a small conversation about it, but I'll hand it over to you.
Okay, well, I hope I don't repeat anything, and I apologize for being late. Thanks for your understanding. So the board has all seen our public health improvement plan focused on mental and behavioral health, which is our strategic priority, that emphasized where some of the gaps in our mental and behavioral health work are, or ways that we could strengthen the work. Though we were doing a lot more work across the agency than was really reflected in that plan. With some of the funding reductions and staffing reductions, we tried to really look at this as an opportunity to revision what our work looks like in the future as we kind of rebuild. Um, Over the summer and into the fall, we did reorganize the community health division because the staffing shifted significantly. And of course, that division runs a lot of our mental and behavioral health work. What we tried to do was to keep subject matter experts from the teams so that we had a core team, even as the teams got much smaller, because we needed to have that continuity as we kind of rebuild the new plan. So we've been having conversations during since this summer about what a comprehensive strategic plan for mental and behavioral health and public health would look like, that we could use as a reset in guiding our goals and strategies, as well as informing our grant applications. And just to say, the FIP as a strategic priority will remain intact. It won't necessarily, I mean, it's not going to be discarded. It was useful for this purpose of kind of emphasizing where some of the gaps were. And we also wanted to really take the opportunity to say, what does the data tell us about where we really should be focusing our resources and aiming to rebuild our teams as we go forward. Next slide, please.
Oh, that's.
That's it. That's all we have, Lexi.
Oh, okay. You pulled the slides early today. Apologies. I'll walk
All
you
right.
through what I was going to talk about. Just in terms of the strategies that we're looking at, public health's lane is really around prevention and early intervention. Although our work has included some navigation and recovery support. These were the areas in the behavioral health roadmap that were really clearly laid out as kind of public health's wheelhouse. What we really want to do is in this plan is draw on the most effective work that we've done in this space. We won't necessarily continue everything we've been doing. We won't even necessarily be rebuilding towards that. What we really want to do is say, what's the most effective work, and how can we make it more strategic, a little bit less opportunistic in terms of, well, there's a grant on mental and behavioral health, let's apply for it, but really having a vision of what we're trying to create and how we would see change in the community based on that. That also really allows us to leverage a lot of our internal work and our work with partners to create kind of a more seamless and aligned approach. And so using a lot of population data to look at the priorities, making sure that the interventions that we're looking at are really evidence-based, and starting off the work with KPIs that can guide us as we go forward, and really support the learning process. What we've kind of looked at is really recognizing that there are 3 life stages that our agency is focused around. And these 3, we think that these are the right life stages because these are areas where there's a lot of vulnerability. Oh, look at you. You guys are so good.
Sorry that took a minute.
Nope. Thank you, Patrick. So moms and babies are kind of that first group. We know that the data tells us that postpartum maternal mental health is really bad in Colorado for some reason. We have a lot of morbidity and mortality that is completely preventable. And this is a space where we can make a difference, and we have been. We rely on our infant and early childhood mental health consultation team of 2 whole people. They are remarkable and wonderful in terms of being able to go into a situation that some of our home visitation programs have identified. There might be a mom, or they might be seeing stress in a young child, and they can come in and really support them to create a positive environment, and create referral supports for moms and kids both. We also have Genesis, which is our Teen Mom program. They work a lot with families that are under a lot of stress. Teen moms are particularly vulnerable to mental and behavioral health issues. And our Family Connects program, our NFP program, they all draw on the IECMHC Infant and Early Childhood Mental Health Consultation team. We also know that the data shows that there are a lot of ACEs, adverse childhood events, that are preventable. And Genesis, for instance, really, and Family Connects really focus on reducing ACEs. So the strategies are really around positive mental health, parenting, early consultation, and mental health and behavioral health navigation. We have some new work that's going to be emerging in this space with moms and babies around Family Connects is creating a baby cafe to create some pro-social events for moms. Their community advisory board thought that that would be something that the clients would really appreciate. And so they're going to start doing, creating that opportunity. The second group that we really focus on is adolescents. And our programs, our Genesis program, our Oasis program, Generations, CSAP, which is Community Substance Abuse Prevention, and the TEP, which is Tobacco Education, really largely focus on youth and adolescents. This is a time of a lot of stress for kids, for people growing up, and there are some populations that we see that manifest in particular, LGBTQ populations, Latina populations, any youth that's marginalized, and then also teen moms. What we really focus on in this space is creating protective factors for prevention, making sure that kids have trusted adults in their lives, supporting family dynamics and social support, such as in the Genesis program, using youth leadership as a strategy for developing locus of control and confidence, which are protective factors. We're also building on our All Fact, No Cap campaign, which is a youth developed campaign around tobacco. And then we also do a lot of work on youth overdose prevention, trainings that are financed by the Regional Opioid Council. We're looking at how can we do a better job of kind of scaling up the work to reach more youth. What are some of the gaps that we're starting to see with schools as some of the executive orders force them to pull back in some areas around vulnerable populations that we think are really important? Is there going to be a need for us to fill that more? How can we work with partners to make sure that those gaps are filled? And then also looking at, there are some spaces around policy and systems change that we also want to be incorporating into this work. And so one of the issues for adolescents in particular is reducing access to high THC marijuana. And then the last group is adults. Programs in that area include the Works, the Community Substance Abuse Prevention, SUAG group, and then CEDAM runs the Fentanyl Working Group. We really focus in this space on adult overdose prevention, on recovery treatment and supporting navigation and referrals through the Works program, the Let's Talk campaign that Sean shared with you. The SUAG, which is the Substance Use Advisory Group, is a collaboration run by our CSAP program that includes members of the community with lived experience and informs aligned planning for a number of different groups in the community. And then we also have a fentanyl working group, which has been really successful in reducing fentanyl deaths. We work very closely with the DA, the coroner. One of our commissioners often comes to this meeting. And we provide data through OD map, overdose map, which can inform the planning. And as I said, we saw a lot of success in reducing fentanyl deaths. What we are starting to see more of now is actually meth deaths. And we're talking about whether that fentanyl working group might begin to pivot a little bit to address meth. It's a trickier intervention. There's not a medication to reverse it. It's under consideration. Also looking at kind of leveraging some collaborations that are happening in our community and regionally around firearm safety. The DA and some local churches run a gun safe giveaway. That's something that would be easy for us to help with. There is a regional approach emerging to reducing alcohol abuse that we are looking at being a part of. We used to have an alcohol prevention program in public health, and we sunsetted a number of years ago. But if you look at the burden of disease and the expenditures on healthcare, there's a huge return on investment by investing in this space. And then maybe also looking at recovery-friendly work environments. Now, I've just thrown a whole lot at you, and there's no way in the world that we could address all of that at once. So part of what we'll be doing is really identifying where do we start and how do we build this successively in a way that allows us to best leverage what we're building as we continue to build it. So the idea is to create a base plan and budget, and then to build out something that's more of a full implementation plan as possible. We are going to be bringing this to the strategic planning committee, and we are also making sure that we're having conversations with the behavioral health roadmap teams and planning with community services to make sure that the work is still fitting together nicely. And that's all I have for you on this initiative that we have been working on.
Questions or comments?
Yes.
Go for it, Steve.
Hey, Lexi, thank you. Actually, I was going to ask about the plethora of things that are going on and how does one go about prioritizing that, given the budget environment, et cetera. So it sounds like that's to be determined in terms of working out the approach.
So we were very intentional about not sunsetting our most successful work and making sure that we have, stable funding to continue that work. The strategy may be to begin by adding components where we're really leveraging existing resources. So for instance, if we're part of the firearm safety campaign, that we are making sure that our home visitation programs are able to distribute gun safes to clients or other outlets like that. The alcohol prevention work it's gonna take a couple of years to get going. It's a regional approach. And so as we are participants in regional entities, we'll be following that along with that and looking at where we can leverage the kind of collaborative work that's happening in that space. So a few of those kind of examples.
So a lot of these high-risk behaviors, I imagine, I don't know, again, I'm not an expert in this area, but do they have sort of a common source or I'd say exposure that people go through to either seek alcohol or alcohol consumption or different type of drugs? And I'm just wondering, is there a way to more holistically bring some of these behaviors into a common umbrella? And would that be more efficient, or is it might be too naive?
No, I think that's a great question. And there are, I think that social isolation leads to a lot of this. And, the antidote for that is really tying people into pro-social activities. Teaching people positive mental health, You know, we often focus on the deficit, but if we're able to also teach people positive mental health habits, then that becomes a protective factor. And these are some of the things that we've been thinking about. You know, how do we use a population level approach for this? Whether it's policy, systems change, communications campaign, whatever. So I think that what you're picking up on is really important, and it's part of an effective prevention strategy.
Anyone else?
Okay. All right.
Thanks, Leslie. The Strategic Initiatives Committee looks forward to working on it with you.
Great.
Item 6, Director's Report.
Any questions on the director's report or anything? Yeah, any questions first?
Always very helpful update for us. Thanks for putting it together.
Nothing else to share on? All right, then we're moving right along.
All right.
I'll just say a little, some good news is that the Colorado General Finance Officers Association presented an award to our team for the priority-based budgeting work that we did, and they'll be accepting that on Thursday. So very proud of them for that.
As are we. Item 7, old and new business. Going once.
The popular category.
I know. You guys are being kind to me in my first meeting appreciation. Item number 8. No further business. This meeting's adjourned at 6:57 p.m. Thank you.
Yes.
Nicely done, Amber. Great
Thanks,
work.
Morgan.
Good job. Where's the gavel?
Thank you all.
She takes it all.